Did.
Support the bipartisan law, repeal the flawed SGR formula, as you know, originally introduced in 1997 to determine the Medicare fee schedule fee-for-service payments. As you know, over the past several years, the application of the SGR would have resulted in annual decreases to the physician's payment were it not for recurring legislative patches. So in SGR's place, MACRA requires physicians to choose between two payment paths, and that would be the merit-based incentive payment system, or MIPS as you will hear it called most often, and the alternative payment models, or APMs, beginning in 2019. We'll explain the two in just a moment. MACRA focuses on moving Medicare payment from volume to value. And if you had an opportunity to peruse the 962 pages of the Federal Register, you'll also see that it includes several other payment provisions and offsets totaling $39.5 billion in savings over 10 years. So it extended the GIFC, it's got extended funding for hospital projects, the 2 midnight review activities, and shifting enforcement of the rule from the MAC to the QIO. So there's a lot of information that is available for you as well. All right, let's take a closer look at the Merit-Based Incentive Program, or MIPS as it's most commonly known, on page or slide 5. The MACRA legislation only addresses Medicare physician and clinician payment adjustments. The proposed rule seeks to streamline a variety of Medicare payment programs into one quality program. So that means that the dreaded PQRS, EHR, and the value-based modifiers that haunt you today will sunset December 2018. What will be involved with MIPS? As we said, it's going to consolidate 3 separate programs into a single program, and it adds a 4th component to promote ongoing improvement and innovation clinical activities. Beginning in 2019, it will replace the payment cuts associated with PQRS, meaningful use, and the value-based modifier, with the potential to earn a bonus or incur a penalty depending on your performance score. MIPS provides clinicians the flexibility to choose the activities and measures that are most meaningful to their practice to demonstrate performance. Let's look at who our eligible clinicians are. At least the first 2 years, you'll notice on slide 8, our physicians, PAs, nurse anesthetists, NPs, clinical nurse specialists, and groups that include such specialists. Other professionals paid under the fee schedule may be included in the MIPS beginning in 2021. Notice, MIPS does not apply to hospitals or facilities. Again, the merit-based incentive, or MIPS, combines the existing Medicare reporting requirements into a single entity that ties fee-for-service to performance on an overall physician quality score. Although this figure is not to scale, you can see that MIPS will be the pathway for most physicians in the Medicare program. A few more qualify for the alternative payment model, and then even fewer qualify participants in the advanced payment model. We'll look at those in a little bit more detail in just a moment. Will it affect me? I'm glad you asked. On slide 10, we've indicated that there are 3 groups of clinicians who will not be subject to MIPS, and those who are in their first year of participation in Medicare, those who have a low volume of billing charges, $10,000 or less, and those who have a low volume patient threshold, 100 or fewer Medicare patients, or those who are receiving their monies from eligible alternative payment models. Those three categories will be exempt. Hospitals, facilities, your Medicare Advantage, all of those do not qualify under the new program. On slide 11, let's see what physicians have to do. This chart gives you a visual of the MIPS Unified Scoring System. The annual MIPS Composite Performance Score includes these four categories: quality, cost, clinical improvement activities, advancing care. CMS will start to collect the data in 2017. Notice that each performance category is assigned a weighted value, which can change each performance year, as I'm sure you've seen. On the next slide, we give you a little bit more information where we actually tell you the individual years that have been that are part of the legislation so far. The composite score factors in the four categories: quality measures, resource use, clinical practice activities, and advancing care. Methodology has been developed to determine a composite score, 0 to 100 points for your providers. As with the current quality programs, MIPS incorporates penalties and bonuses. Clinicians receive a positive adjustment factor if their score is above the performance threshold, or a negative adjustment if their score falls below the threshold. Notice the last column where it says MIPS adjustment factor. There's a sliding scale of 4 to 9% depending on the year. The adjustment can be positive, negative, or 0. It's budget neutral, which means the losers fund the winners, and then physicians are also eligible for additional bonus of at least 10% for exceptional performance. In year one, we'll just do it briefly. Notice the quality measures 50%. This replaces the PQRS and the quality component of the value-based modifier. So in this particular category, clinicians will choose 6 measures as opposed to the 9 that are required now. In the cost and resource, this measure replaces the cost component of the value-based modifier program. CMS will calculate this score based on the claims you send in and the availability of sufficient volume. So there is nothing you have to report, but the claim volume they already receive will give up your score on this particular category. The clinical practice improvement activities, the physicians will be rewarded for clinical practice such as care coordination, beneficiary engagement, patient safety. Under the beneficiary engagement, how quickly can they get an appointment, things of that sort. You can choose activities that are best suited for your practice from over 90 options. In the advancing care information category, lastly, 25% is the weight in this one. This measure replaces the EHR, also known as meaningful use. For this category, you must use certified EHR technology, and you'll report a customizable size of measures that reflects how you use EHR technology in your day-to-day practice.
We have a couple questions.
Okay.
I think Emil is asking, how will clinical improvement activities be measured?
All of the measures will, they have a point system. So to receive the points, the physician and other clinicians must simply provide the numerator or denominator, so it's going to be a yes or no for the objective measures. So you'll actually have to go to the Federal Register, and there's an actual table in there. So there will be, they'll give you an idea of what those activities are, what are considered the advancing care activities. and then you'll determine whether you can say yes or no to the denominators that are there. And that's your performance is based on that part of the score. And unlike the existing meaningful use program, this does not require an all or nothing. You can get some points for actually working with the technology.
And then are these set in stone? Because the program is starting in 2017.
The program starts in 2017, but right now we are just talking the proposed rule. So actually this is proposed rule. The comments closed June the 27th, and the final rule is expected out late fall, October, early November, with all of the final regulations.
So I want to go back to another question. Emil said, I saw a patient with diabetes, high blood pressure, and high cholesterol and billed CMS 99214. Normally, I would receive $91 with the following week for this type of charge. Now, what will happen in 2019 according to the above breakdown? Is this something we can talk about today, or?
Right, that's nothing that we can talk about today. That's going to still come, the 99214 is still going to be on your fee schedule. So your performance score here is not going to be affected by what you bill and how much it costs. They're going to have to gather that particular data, and you have to see what the requirements are under advancing care. That's using your technology. Your clinical practice activities would be your patient safety, your patient engagement, your resource use. You won't be able to affect that at all. CMS will use their the data that you sent in, and then your quality measures, you will be able to choose those. So that shouldn't be affected at this point.
Next slide.
Let us pick it up, the conversation at slide 13. CMS will begin measuring performance for MIPS. This was the one of the questions that Emil was just asking, was they want to start with this particular program January 1st, 2017 through December 31st, 2017. Although it's not final, as you just heard, and the final rule will not be published usually until October or November, that means, as you're hearing, that less than 2 months to go. Since MIPS combines your PQRS, your value-based, and your meaningful use, the last performance period for these programs is December 31st, 2016, and the payments will sunset in 2018. And definitely with less than 4 months to go right now, the push is definitely on from AMA, CMA, and all of your other specialty societies to delay the start to July 1st, or to shorten the reporting period from an entire year to maybe 90 days. However, we won't know that until final rule in the fall. So we're still trying to impress upon our physicians to get some knowledge on the program and to get ready. Let's turn our attention to the advanced payment model participation. We're on slide 14. For clinicians who take a further step toward care transformation, the advanced alternative payment model rewards those physicians who are participating in payment models that attempt to incentivize healthcare decision-making based on quality, outcomes, cost savings. So if you're able to participate in this one because you're a little bit further ahead of the game than a lot of the other clinicians, you will have an opportunity to receive a lump sum payment bonus to 5% your Medicare charges. You'll have a significant part of the Medicare population that participates in the APM, and you're also taking a greater risk. Physicians participating in the approved APMs will not be subject to MIPS, as we just talked about a minute ago, positive and negative adjustments, but will instead receive a lump sum incentive payment. And later on we'll talk about receiving a little bit more in your fee schedule updates as well. What is the alternative payment model? Here we kind of give you an idea of what's defined by MACRA. The APMs incentivize quality and value, and they include the CMS Innovative Center models. your Medicare shared savings programs, demonstrations under the Healthcare Quality Demonstration Program, and any demonstrations required by federal law. So there are a number of APM options, probably not all voted on by CMS yet, but they are coming into play. Next, we show you that part of the criteria for the APM is that you must use certified EHR technology. It bases payment on the quality measures comparable to those in MIPS. The APM definitely bears more nominal financial risk for monetary losses, or it's a medical home model expanded under the CMMI authority. So here you have an increasing percentage of payments linked to value through Medicare or through other payer APMs. Under MACRA, we're moving on. We show you, give you kind of an example on slide 18 of some of the models, the comprehensive ESRD model, one of the new ones, the comprehensive primary care plus, as we said before, the Medicare shared savings, tracks 2 and 3, the next generation accountable care org model, and then the oncology care available in 2018. On slide 19, we put it all together. The top line is the fee schedule updates. 2016 through 2019 is a 0.5 each year. 2020 through 2025, you'll notice there's a 0% update in the fee schedule. This is to get everyone to kind of level out, get in the two payment tracks. And then 2026, you'll notice 0.25 or 0.75. The 0.75 is for those APM physicians, and then the 0.25 is for everyone else. The second line is the MIPS maximum adjustments, 4 to 9%, depending on the performance above or below the threshold. So it could be a plus or a minus on the sliding scale. And then the last line is the alternative payment model reimbursement. Physicians will receive the 5% lump sum bonus. And notice the APM, it definitely has a little bit more money built into it because it has the higher risk, and it is trying to get a lot of the providers to move from the MIPS to the APM model. Couple points we want to review. MACRA changes the way Medicare Part B pays the clinicians, and it offers incentives for providing high quality care. There are two pathways to choose. We notice in year one, for the most part, most providers will be on the MIPS track. I have seen some estimates as high as 90%. There are only 3 exclusions they're showing so far, and that's if you're in your first year of Medicare Part B participation, you have a low volume, less than 10,000 or less than 100 patients, or you participate in the advanced APM, which of course takes you on a different track with the risk, you're meeting the required patient load and charges going through the program. The payment adjustment and bonuses begin in 2019 based on 2017 performance, and the final rule, once again, is not targeted until fall 2016. So there will leave very little time to get this underway. On the next slide, we talk about the MACRA strategy.
Cheryl, before we go on to that, I just want to see if you saw Emil's question about preparing for 2017. He said, I think what's confusing about MIPS is that we have a very solid understanding of what we do right now based on FFS, but MIPS is a little surreal. So as we progress through this webinar, it would really help to pin down some things that we can do now in preparation for 2017. By the way, giving the entire physician population 2 months to learn something of a new language seems like a formula for tension. So I don't know if we want to come back to that or if that's going to be something we're going to need to address separately, because I know you have a lot scheduled for today.
Well, the question of the 2 months to do a lot of the information, Emil is perhaps giving the opinion of a lot of the providers. That's why you'll continue to hear me say it is 2 months, and CMS knows that. And so we're a little unable to address that, except to let you know that AMA, your CMA, the specialty societies all have a technical committee that is responsible for letting CMS definitely know the opinions of our membership providers. So also on slide 21, you'll notice that I have indicated that CMA has a MACRA position statement. So if you go there and you click and you go to the cmanet.org, you can go into the letter that CMA actually has sent out. So a lot of your comments are definitely echoed by a lot of other providers. Also, this particular rule, there was a comment period. So everybody got a chance to send in the comments before June 27th, letting CMS know exactly how they feel. Andy Slavitt is from CMS, and he realizes that the window for preparation is not large enough to get for everybody to be successful. As you said, with the older programs, everybody was successful. So they've got some things that maybe they'll consider changing the start date. Maybe they'll consider a shorter period for reporting. CMA has definitely asked for exclusions in terms of which physicians can be excluded from the program. Right now, it only says those who have less 10,000 or less their patients, and they find that that doesn't cover a lot of providers. So they're also proposing that those numbers will be increased. And then later on in the presentation, I also have a list. We definitely had a checklist that we sent out with the PowerPoint today. So we put out a checklist that CMA has that they also have done behind the scenes, where we believe that you can possibly do some of those things to kind of ease the burden. But right now, the start dates have not changed. Okay.
Okay. So you want to move
okay.
on to...
And we're right where you want to be, Neil. Everyone else, preparing your practice for MACRA. Here's some things where we hope will make the transition a little bit easier. Here's a few of the nuts and bolts you can take now to prepare. First, learning about MACRA and being out in the community and talking with a lot of our clinicians. They know none of the details, so that's first and foremost, is at least knowing that it exists. I'm sure everyone's not going to read the 962 pages that were part of the proposal. However, CMS does have a 14-page summary that gives up a lot of information. The professional society meetings are going forward. LACMA is scheduling meetings within the districts to try to fill everyone in. Your societies may have data registries that may make it easier to participate. They should have efforts to train and advocate for physicians on MACRA. We also participate in 2016 quality reporting. I know that wasn't easy, but at least kind of get in tune to what the requirements are. Review the quality and resource use reports. I've got that on a slide for you in just a moment. using the certified EHR as a part of your workflow, contacting the vendor that you use to ask them questions, training, timelines, a lot of those things. And then slide 24, like I said, has a fact sheet and support for small practices that has been developed by CMS. So it has a lot of information it believes that you can use to get ahead of the game. $20 million has been voted on for 2016 through 2020 to help the small and rural practices. CMA is trying to also tap into seeing if they can get some part of that pot to definitely help our physician community. As we said, we've got a preparation checklist here on this link, and we also attached it. And then CMS has a number of education materials. And I know CMS website has been known for not being user-friendly, but I can say they definitely have had a number of programs since March. They've got slide decks that you can use in training yourself or train the trainer. They've got short slide decks. They've got some that have as many as 95 slides, depending on where you are in the process. Okay, so we're going to continue an ongoing conversation on this particular issue while we wait to see what dates they're going to go forward with. On slide 25 is where I talk about CMS has sent out a number of messages regarding the release of the PQRS feedback reports and the quality reports. They kind of give you a snapshot of what your 2015 reporting results look like. They will also give you an idea of the negative payment adjustments. So for those providers who haven't participated or who were not successful, soon, early fall, they're saying they have not given up a date, but last year was around late September, early October. They'll start to send out letters so that you can get an idea of what you've done in your practice versus what their expectations are. I know it's a little bit late in the game, but at least it'll give you a starting point to look out for. The feedback reports for 2015 can be accessed, and as you continue to see 2015, because it affects 2017's money. So that's why you continue to see that particular report. Here I've got a link to a lot of the instructions. When you open up that link, it will be overwhelming. I did go there, but the information is on the right-hand side, upper right, what you're looking for, okay? Also on slide 49 in today's presentation, you want to ensure that you're on the mailing list. The best part of or securing the knowledge that you need to be successful is at least to see what they send out. And on page 49, when I tell you to sign up for the provider e-news, it's a one-page document that usually comes out on a Thursday. Very valuable information. You take what you need and get rid of the rest. The EHR payment adjustments are quickly coming. The EHR Meaningful Use Program was introduced in 2009 to incentivize the adoption of electronic health records. 2015, those who did not successfully demonstrate meaningful use were subject to a negative payment adjustment. The penalty in 2017 will be 3%. We've already talked about the fact that meaningful use will sunset and it'll move under the MIPS program, and they'll call it the Advancing Care. Okay. The Recovery Act allowed for a hardship exemption. So those of you who are on the line, hopefully you filled out the application. So this 3% payment reduction, you received a free pass from this one because CMS acknowledged that they changed the rules and regulations in October of 2015, too late for everyone to get their EHR information in. So there was a free pass that CMA, AMA, everybody, all of your specialty societies would have published that you could fill out a one probably about 7-page application, but it only took you about 5 minutes to fill it out. And then you should get an exemption granted from receiving this payment adjustment. So hopefully most of you did that. All right.
So we're at our 5-minute mark.
Okay.
So just so everyone is aware.
Okay. So we're coming up, EHR meaningful use. Just want to remind you a couple things on your post-payment audits. Your supporting documentation is retained for 6 years. I've got a tip sheet that's built in there, probably about 10 pages that will help you with getting up to speed on EHR, talking to your vendor. And then also on slide 28, I gave you the incentive programs assistance, who you can call, Quality Net Help Desk. Slide 29 gives you the CMS resources, the links to the Federal Register in terms of actually seeing all of the rulings that have come down to PQRS, value-based modifier, EHR. I know it's a lot of information that's always not easy to follow if you've never been in the program, but this kind of assists you with the process. Let's see. Deborah says we've got about 5 minutes. I gave you a lot of other slides. Don't let those bother you, okay? I believe in giving you a little bit more information. I think you'll be able to go over it. It kind of gives you a heads up regarding ICD-10. The freeze is over this year. Remember, there was a 1-year grace period. We've already turned around on that year. So I've given you some reminders regarding what your ensuring your documentation supports what you do. Also, an update section in regards to the physician fee schedule is out there now for comments. The GIPSY will be phased in. The enrollment revalidation cycle has restarted 5 years later. On slide 40, you want to make sure that you go out and you go to the website and see if you are due for revalidation. So we skip down a few. There we are, slide 40. This is probably one of the most important ones in the entire batch. Go in and see if you are due for revalidation of your Medicare enrollment. If you see a TBD, to be determined, that means you're at least 6 months out. You can go ahead on and rest. The Noridian has reported that only 19% of the providers who were due for revalidation, May 31st, June 30th, and July 31st have responded. That means that August 14th, in 4 days, they are going to be deactivating all of those providers who have not responded to their notices in May. Those who didn't respond to the notices in June now have their monies in a pending status. Once they deactivate you, no retroactive privileges. All right, so this is the most important slide in the almost in the entire presentation today. All right, gave you a couple other reminders also. On slide 45, I give you the odds that are going forth by the contractor.
What's wrong one?
Here. This one kind of gives you some places to start in terms of auditing. Slide 46 reminds you that if you talk to the beneficiary and they agree to pay for a service, don't put their Medicare number on the ABN notice that you've given them, or it renders it invalid and your services have been rendered for free. Slide 47 gives you information on your HIPAA updates. Definitely those will be part of your EHR advancing care information in the new MIPS model. Want to make sure that you have your security risk updated. The on-call documents are on cmanet.org. So we have a number of documents that will help you with getting your HIPAA up to standards. Education and resources 49 I talked about earlier. Make sure you sign up. This one keeps you in the know. 50 is, keep going, one more. 51, that's your resources and your education. The webinar schedule for CMA, LACMA will add also, and then slide 51 is our reimbursement hotline. It also gives you a way to contact me if you have some information. Essential to the practice survival is payer relationships, practice leadership, communication, and training. So in the coming months, we're going to expand our webinar. All right, I think we made it through the slide deck.
Yes, thank you, Cheryl. Thank you, everyone, for joining us and your questions and comments. Thank you, Emil. Yeah, we would love to follow up and know, what was most helpful. What do you need to hear about more? Are you interested in another webinar? I'll be sending out a survey to you just so we can collect that information, because we very much want your feedback to know what you guys need, especially with all these updates that are coming your way. So thank you, and enjoy the rest of your afternoon.
Thank you, everyone.
I should mute everyone. There. Everyone's unmuted if you want to. Thank you.